That's a really important, I think, several important points. And having said this, what do you think if we talk about future outlooks? Do you think that future guidelines will still expand the indications for intravascular imaging to do it, how you already said, for non-complex PCI? Because I think the biggest question for me, and I stated it out several times, is to say what is complex, what is not, because sometimes you just identify complexity by doing IVUS. So I would say you oversee a lot of complex situations by just doing angiograms. And the future would be, from my point of view, if you think about this, if we have better streamlined workflows, maybe just some improvements in the technical aspects of doing intravascular imaging, to have it available in your cath lab, not as an add-on, but to have it already on the table, so it decreases the time of the procedures even more, decreases the amount of contrast dye. So from my perspective, the future of intravascular imaging would be to apply it in every intervention, in combination maybe with perfect pre-procedural screening, for example, MRI or CT scans, so that we have pre-selected patients coming on the table for the intervention, and the intervention will be performed perfectly by the use of intravascular imaging, if it's either complex, non-complex, or if it's a stable or unstable patient. This would be my vision of a perfect intervention, because if you ask me how I would have placed a stent in one of my coronary arteries, I would say, please use intravascular imaging to look if the stent is well positioned after implantation. So what do you think about this?
Well, I think you made a very important comment here. I think that's what most of us would do, right? I mean, if you've seen what IVUS or imaging can do, if you've used it, I mean, you will start learning to appreciate that the angiogram is misleading. So not using it, to me, doesn't make a lot of sense. And I agree with you that within now and perhaps a decade, the use of imaging will be expanded, not just complex PCI, but I think is also in a specific area in which the use of imaging may be extended is in patients with ACS. As I already alluded to, in patients with ambiguous disease, in which likely things are not always that obvious. But it could just as well be that lesions that look very short and focal actually are tremendously calcified if you do imaging. And then suddenly this simple type A lesion turns into a type B2 lesion simply because of a 360 degrees concentric amount of calcium. So if you don't look for it, you will not see it. And I think with that perspective, most of us agree that you should have a low threshold to use imaging. That said, there are always a couple of examples in which perhaps the use of imaging doesn't make that much sense, like some patients presenting with cardiogenic shock, patients presenting with degenerated vein grafts in which you're going through the third PCI because of the native system is totally occluded and calcified. These patients will come back anyway. So you could argue whether this is the ideal population where you will get your 25% mortality benefit. Honestly, I don't think so. But that is something that we can dispute. But that again does not apply to the 90% of our practice which forms the remaining part.